Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, a physiotherapy student at the University of Toronto. Pain is not only a conversation to have among adults. Children experience pain too. If you're a parent or a healthcare provider, you will have to work with children in pain. What is the latest evidence on pediatric pain management? How do we make sure that children's pain are well managed? And what are the consequences of poorly managed pediatric pain? I have the privilege to interview Dr. Christine Chambers, who is a leading Canadian researcher and advocate on pediatric pain. Before we jump into this episode, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division nor the Canadian Physiotherapy Association. Enjoy the episode. Hi, Christine. Thank you so much for spending some time out of your very busy schedule to be on Paincast today. I really look forward to the conversation. How are you doing today?
I'm great, and thanks so much for having me.
Amazing. To start off, can you introduce to our audience who you are, what you do, and what a typical week looks like for you?
Sure. So my name is Christine Chambers. I'm a professor of psychology and neuroscience and pediatrics at Dalhousie University in Halifax, Nova Scotia. And today I'm joining the podcast in my role as scientific director of SKIP, which stands for Solutions for Kids in Pain. And we are a national knowledge mobilization network dedicated to bridging the gap between what we know about pain management from research and then what actually happens in practice and policy for children in pain. And what a typical week looks like for me. One of the favorite things about my roles and my job is that no 2 weeks ever look the same. I have a chance to work with amazing people, both in my lab. So I run a research lab at the IWK Health Centre, which is our children's hospital. And our SKIP network is based at Dalhousie University. So working with incredible people locally, but also nationally, folks who are really committed to improving children's pain. So any given week, I usually have a lot of meetings, but also a lot of opportunity to travel, to be at events and activities. Every week looks a little different, and it's always a mix of really interesting things.
Yeah, looking at what you have got in the SKIP website and also the It Doesn't Have to Hurt website, I thought that's a lot of teamwork and effort put in to educate the public and practitioners about bettering pediatric pain management. And it seems that you're just so passionate about this topic because otherwise you wouldn't have organized or started this knowledge mobilization effort. Why are you so passionate about advocating for better pediatric pain management?
Well, thanks for that. And it's been a long road. I started studying children's pain when I was an undergraduate student at Dalhousie 30 years ago. So I really got hooked on research. I'd always wanted to be a child psychologist, so I'm trained in psychology. And I always imagined that I would be working kind of directly clinically with kids. But through completing my PhD, I just became completely hooked on research and started my own lab, was publishing papers in journals, giving presentations around the world. And I thought I was making a difference for children in pain through all of that. But when I had my own children, so I'm also the mom of 4 kids, now they're 4 teenagers, and I realized that all this great research that I had spent a whole chunk of my life, my career contributing to, again, publishing in journals and presentations, wasn't actually making a difference for my own kids. So when I would take my children into medical appointments, when they would have surgeries, hospitalizations, I just experienced this huge, what we call kind of like a knowledge to action gap, where I knew what the state of art was from the science, but yet that wasn't what my children were benefiting from. And there were many times where I had to advocate strongly for my own kids to receive what I knew to be evidence-based pain management. And it really made me wonder, what about every other kid, right? Who doesn't have the benefit of having a pain expert for a mom who can push and say, well, actually, the research shows this, or I want us to do this for my kid's pain. So that personal experience really created a pivot in my mind, because if all this great science, again, that I had contributed to wasn't benefiting my own children, like what was the point? And I had the opportunity to participate in a fellowship. So this would have been about 12 years ago, on media and advocacy and policy. And I started taking courses on knowledge translation, knowledge mobilization. And then I started to experiment. And so the first thing we did was we created a video for parents as part of my fellowship. It's like a really brief 2-minute video in which a 5-year-old girl tells parents what they should and shouldn't do to manage their children's pain during needles, all based on research. So it was that kind of series of events and experiences that led me to realize that we needed to do things differently if we wanted our research to make a difference for kids in pain.
Wow. I totally appreciate that you had that pivot and decided you wanted to take that on, because if you don't do anything, then the state of pain management for kids will still stay the same. Would you say that it has changed over the past 10 years?
I think so. I think that we're part of a large community of people nationally and internationally who are trying to make a difference for not only kids in pain, but people in pain. And so I think the last 10 years has seen a much greater awareness about what pain is, and that it's important, and that pain can be prevented, and that pain can have immediate and long-term consequences if not managed properly. So I think there has been an increased appreciation, increased awareness. And we've certainly come a long way from the 1970s and 1980s, which is sort of when the field of pediatric pain research was born. The reason people started studying this was because it was widely believed that babies didn't feel pain, that they were too neurologically immature to feel pain, that it was too risky to use anesthetics with them. So they were often undergoing major procedures, even surgeries, just with paralytics, like they were given nothing for pain. So we've made remarkable progress in the last 40 to 50 years. And I think we've really built a strong evidence. We're still building research in the area, but we've also come to appreciate that the awareness, the willingness, even the Canadian federal government had appointed a Canadian Pain Task Force, and there are reports. So just general awareness raising has created opportunities for us to move the needle further for kids with pain.
Before we go into more details of the best practices that your research and your knowledge mobilization efforts emphasize for bettering kids' pain management, help our audience understand this topic. So first of all, why is children's pain a topic on its own, separated from just better pain management strategies in general for everyone across the lifespan?
We often say that kids aren't just little adults. And so children and childhood is a period of rapid development and evolution. Children have much different communication abilities, developmental levels. So if you even think about pain assessment, for example, with adults, typically because pain is subjective, we ask them how much pain they're in, right? We say on a scale from 0 to 10, how much pain are you having? Some children, older children, can do that. But in younger children, children with cognitive delays or cognitive impairments, babies, they can't tell us how much pain they're in. So researchers have had to be very clever around how to develop tools and assessment measures, often utilizing facial expression, for example. So there are a lot of common themes to pain in children and pain in adults, but also some added complexities that I think has made it a field in and of itself. And that's not uncommon, I think, in pediatrics across various health issues. So it's allowed us to really have a focus and be able to bring people. I mean, I hadn't been someone who was interested in pain. I was interested in working with children, but was exposed to pain and was drawn in. So I think you often have a mix of people in the field who are really coming at these issues from a pain perspective, or they're coming at it from more of a developmental lens. And I think that combination of interests is beneficial to the field.
So you highlighted one of the major difference, which is how kids are able to express their pain. And that is very different from how adults can express their pain, understand the pain scale of 0 to 10. I'm also curious, is pain experienced in children different from pain experienced in adults?
Right. Interesting question. And again, historically, people thought that children felt less pain than adults or weren't capable of experiencing pain. And there were some of the landmark studies in the field in the 80s that showed that children were consistently given less medication, adjusted by size and so on and age, but they were given less medication for pain than adults were for similar surgeries. So I think there's been this longstanding belief that children don't feel pain the same way adults do, but certainly the research doesn't support that. And if anything, some of the research shows that younger children may experience more pain, like their abilities to regulate may not be as fine-tuned. Children are heavily dependent on their parents and other caregivers for support. We've really evolved our understanding of pain in children, and I think for the most part, people appreciate that pain is a problem for both children and adults, and that children may be at increased risk for pain because of, again, some of those complexities of childhood and development.
If it's possible to summarize that difference in the developing brain or the developing pain system that makes it a different pain experience, is there a quick summary of how that is different?
Yeah, well, I'll share one example of what happens when you don't properly manage pain as it relates to brain development in children. So often people say it's just a needle, it'll be over, there's no long-term impact. But what studies have shown is that when babies, and people have done this in animals as well, so there's evidence from animal models, but when babies experience pain early in life and it's not managed properly, it actually can change the way that the brain experiences pain and make them more vulnerable to pain later in life. So again, there was a classic study led by a colleague of mine, a pharmacist, Anna Taddeo in Toronto, that looked at groups of baby boys who had been circumcised, and those who had been circumcised without proper anesthesia and analgesia showed an increased response to subsequent pain later in their development. And there have been studies of brain imaging as well that has shown that poorly managed pain really does change the brain and can make you experience more pain, not less pain later on. Sometimes people say, oh, you've got to toughen kids up, but that's not the case at all. So it is really fascinating to think about the impact of these poorly managed painful experiences on brain development and the way that our brains and bodies experience pain.
So is it almost like sensitization?
Very much so, yes.
Got it. So you previously talked about how there is currently an increasing awareness that we need to have better children's pain management. Awareness and practice are two different things. What is the current state of children's pain management?
Wonderful question. And I think that despite all of our hard work, that there are still many ways that we're failing children when it comes to pain. So the most comprehensive studies have been conducted probably about 10 years ago, looking at pain management across Canadian children's hospitals. In those studies, they found that children experienced on average 6 painful procedures every 24 hours that they were in hospital, and roughly 2/3 of children had no documented pain management for any of those procedures. So that's just one example. That was a study led by Bonnie Stevens, also from Toronto. And I think what we're seeing, again, it's been a while since somebody has done a comprehensive assessment the same way that that study was done. But what we're seeing, and certainly what we've been focused on at SKIP, is providing, at SKIP, our mission is to improve children's pain management through coordination and collaboration. And so some of our key activities do relate to awareness raising. But as you say, just being aware of something isn't enough to necessarily show that it's being changed. We've been implementing and sort of approaching change at all levels. So one of the things that SKIP has really tried to do is support children's hospitals in seeking child kind certification. So this is a certification that exists to provide to hospitals who are making a commitment to children's pain and there's various criteria they have to show that they're adhering to related to pain assessment, pain management, education of staff, for example. And so when we first launched SCIP and wrote the SCIP application, there was only one Canadian children's hospital that had this child kind certification. So back in 2018, but having just completed 5 years of reporting for SCIP, we're happy to report now that there are 5 Canadian children's hospitals that have child kind certification. But of course, that's a voluntary certification. So another area that we focused a lot on at SCIP, and this has been led by SCIP's Associate Scientific Director, Dr. Katie Burney, has been developing a national health standard for children's pain, which was launched last year. It's actually the first one in the world. And because you can hope that people will want to manage pain, or you can create a standard that we hope will become mandatory as part of accreditation so that hospitals will need to show that they're doing these things as part of their mandatory accreditation. So we talk about change with carrots and sticks. Like we want to incentivize, support change, make sure all the right tools are there. And SCIP has created hundreds of tools over the last few years to help fill gaps, make it easier, but then also by requiring it and really setting a standard for what we expect everyone should do for children's pain.
Yeah, we'll definitely go back to the standard as we talk about the next section of our interview here, but also talking more about who should be reading the standard and idea. I guess we can jump into the next section. So this podcast also aims to help with all sorts of knowledge translation efforts. So I'm hoping that our conversation would also be able to provide the audience, many of them are clinicians, also some of them are researchers, and I imagine anyone interested in children's pain management, practical items that they can do or be aware or knowing that they shouldn't do when it comes to children's pain management. And this podcast is mainly for physiotherapists. So I'm curious if there are any, so one of the major role of physiotherapists is to help mobilize patients, help them get moving, especially after a procedure, prevent deconditioning, prevent atelectasis, so on and so forth. But mobilizing can often be painful. I wonder if there are any guidelines for physiotherapists to gauge the risk and benefits. As we talked about, if children experience pain, they can be in a position of more likely to experience pain later on in life. Risk and benefits of mobilizing children who are in pain after a procedure.
Yeah, and physiotherapists play such an important role in supporting pain management. We often talk about the 3 Ps of pain management. We talk about pharmacological, psychological, and physical. So we work closely, as a psychologist, work closely with medical colleagues, nursing colleagues, physiotherapists, and in chronic pain teams for children, also adults, but you will almost always see a physiotherapist being an instrumental part of that team. And that applies to acute pain as well. So I'm even thinking about the clinical practice guidelines that exist for vaccination pain management even. So an acute procedure, again, they cover all of those domains, the physical, the psychological, the pharmacological. And it's fascinating from the research on vaccination pain is that studies have shown that just the physical positioning of a child when they receive a vaccination can impact their pain experience. So children who are sitting versus lying down, I mean, these are older children, experience less pain when they're sitting versus lying down. So just a very simple example of how just a simple manipulation of physical positioning can have a significant impact. And that actually is one of the clinical practice guideline recommendations is that children are seated when they're not babies on their parents' laps, for example. But certainly in the context of chronic pain, I think it does vary a lot depending on the type of condition, and physical therapists will work a lot with the rest of the medical team to determine what's appropriate. But really that mobilization, keeping kids moving, it's very similar to how we approach this in psychology too. We are often have families whose children have very complex pain conditions and have been out of school for very extended periods of time. And the parents sometimes are like, well, we're not going to send them back to school until we know what's going on with their pain. And we're like, well, until we get them back to school, it'll be difficult to get the pain under control. So it's really this dance, I think, with interventions for chronic pain of making sure that we're mobilizing, whether it's psychologically or physically, in a way that is helping support resolution or effective coping with the pain. So always grateful to learn from our physio colleagues and always emphasizing the importance of those strategies. And the health standard is inclusive, right, of all the different disciplines of people who work with individuals in pain.
Going off of that, when we try to do our role to help kids move a little bit in the hospital environment, despite the pain that they're experiencing, what do you find are the best strategies to explain and communicate that I understand there's still some pain that you're experiencing and you don't want to move because there's pain, but we still have to move a little bit. And how do we gauge how much do we move?
Yeah, I encounter the same issue in our work as psychologists too, because it's hard at first. And one of the analogies that I've used the most with patients over the years is that pain is supposed to be your body's alarm system. Like that's really how it works. We feel pain because it's supposed to warn us that something is wrong, to seek help or to protect ourselves. And then I talk to kids about it's like a car alarm. Have you ever seen a car alarm going off for no reason? And of course, kids are like, oh, yeah. And I was like, well, what are all the reasons that a car alarm could go off for no reason? Could be that the car alarm is oversensitive, could be that someone just bumped the car and it set it off, but it wasn't a serious bump. So that analogy I think has been really helpful. And to say, like, we've investigated, like, we're confident that we haven't missed anything here, that this has evolved into a chronic pain condition, which means that your alarm system is more sensitive or it's going off more than it should. And so we have to teach your brain and your body to be able to continue to function even when the alarm is going off. And we want to try to turn that alarm down or ideally turn the alarm off altogether. So that analogy has often been helpful at helping people to understand that, oh, I don't wait until the pain is gone until I start going back to school or until I start moving or mobilizing, that I'm going to have to start doing, I have to trust my medical team and start mobilizing and moving forward in before that resolves. So that's just one example of a way that I've described pain as an alarm system and how to think about that with treatment.
So that's what's chronic pain. What about acute pain, like after a procedure?
I mean, I think we often tell kids and families that this is a short-lived pain. In the short term, often, if it's hurting, it's good to stop and take a little break. It really is very dependent on what the procedure is, what the child's response to it was, what the treatment recommendations are. So I think it's more complicated and sometimes with acute pain, but the good news is the pain often resolves very quickly and children are able to resume their regular activities.
Now, talking about still an acute environment, how is opioid use different in children compared to adults?
Yeah, so we at SCIP have actually had a whole project that's been led by Katie Burney and members of her team, and really the whole SCIP network across the country, called Youth in Pain. And this was a project that was funded by Health Canada. And the specific focus was to better understand and create tools and supports for effective and equitable opioid use. And obviously, this is a highly sensitive topic, one that has received a lot of attention in recent years. But the reality is, in certain cases, opioids can play an important role in treatment for individuals with pain. So a big focus of the Youth in Pain project was trying to raise awareness about when it's appropriate, tools that people can use to support effective and equitable opioid use, and also just trying to decrease the stigma around opioid use in children and youth in pain. So there's a whole set of tools on our website that we can direct people to. And this project, I think, has been really successful at raising awareness around some of the complexities on that topic.
Yeah, I guess it's really a fine line of managing pain sufficiently so there wouldn't be any long-term consequences that the children would face, but also you don't want them to develop opioid dependency. But I guess also the question is, how easily would children develop opioid dependency, in your opinion?
I'm not a physician, so I tend to try to stay away from answering too many questions about medications and really direct patients to talk to their medical provider around these issues. But again, we do know that there is a role for opioids when they're used in effective ways, and absolutely never want to foster dependence on pain or on medications for pain. But also, and I think this is a big part of, like, we want to make sure that we're using all the tools that are available so to manage children's pain, and that's where psychological interventions, physical interventions are so important. So we really think of that multimodal approach to pain management in kids as being most effective.
We've been talking about the 3Ps, and I have read through the health standards, and I thought section where there were chronic acute pain and chronic pain recommendations for each of these 3Ps were very helpful, and I recommend interested listeners to refer to the health standard. If someone were to ask you, okay, just briefly tell me do's and don'ts when managing acute pain in children, how would you summarize?
Well, there's lots of different types of acute pain. So maybe I'll take procedure pain since that's the kind of pain that is most common that people experience. So what we know from the research literature is that when you're taking kids for needles, for example, and all kids, when you tell them they're going to the doctor, the first thing they say is, am I going to get a needle? Like this is what kids really wonder and think about. So strategies that we know, so some of the do's that are effective, we know that topical anesthetic creams are very effective to reduce pain. So these are creams that you can purchase at the local pharmacy and apply to your child's injection site roughly 60 to 90 minutes before the procedure. A lot of people don't realize that this is an option they can use. So topical anesthetic creams can be a great choice. We also know that distraction and relaxation strategies are highly effective. So making sure you bring some toys or an app on your phone that your kid hasn't played with in a while that they love. But even if you don't have technology, just counting the ceiling tiles on the wall in the doctor's office. I mean, that's something that anybody can easily do. Encouraging kids to relax. So taking deep breaths, getting them to relax their body, imagining that they're a spaghetti noodle and getting their body really loose. So those are some of the things that are really effective and easy. For babies, breastfeeding has been shown to be analgesic. So breastfeeding your baby during needles is recommended and again, effective for that group. Some of the don'ts include not lying to your kids. So sometimes people get nervous about taking their kids for needles. They'll tell them they're not getting one, but always being honest and upfront. Giving your kid warning in an age appropriate way. So depending on how old they are and what they think is the right amount of notice, again, not taking your kid by surprise. And during the procedure, we know that parents often say things that either can be helpful or not helpful. So we know that when you distract your kid again, that's really helpful. But interestingly, there's a ton of research that shows that when parents use reassuring statements, so when parents say things like, it'll be okay, or it'll be over soon, you're fine, that actually increases children's distress and pain. So instead of saying all those reassuring statements, and we've done studies to show that when parents reassure, it serves as a signal to their child that the parent is nervous about something. So that seems to be the mechanism through which parental reassurance increases children's pain. So using distracting talk. We've also learned that it's not just what happens before and during the procedure, but also the way you talk to your child after the procedure. So there is a group of kids who will remember painful procedures as more painful than they actually were. And that can then negatively impact their experience of pain at a subsequent procedure. So making sure that you really positively reframe for kids. You did a great job coping with that. You didn't think you could do it, but you did it, providing some sort of reward or something to look forward to after the needle. All of that creates more of a positive narrative around the experience. So those are some of the do's and don'ts from the research literature.
I'm sure many of our audience who are parents would find this really helpful. I'm also curious from that perspective, if you're taking a kid to doctor's office, what would be something that you want the doctor to do or want the doctor to not do? Or if you see the doctor starting doing something that you would want to advise or have a conversation about that? Or are there any things that parents would pay attention to in that regard?
Interestingly, the research shows that many of the same things that work for parents, so the same types of language use, for example, also apply to physicians and nurses. And I think for parents, don't be afraid to ask healthcare providers. So even if you end up in the emergency department with your kid, like just say, what are we going to do about my child's pain? Like that's the question I often recommend, because it creates an expectation on your part and their part that something will be done and also that something can be done. Especially in situations or environment like an emergency department where things are pretty fast paced, it can help sometimes to say, like, what are we going to do to manage my child's pain? I also tell parents on our SCIP website, we have handouts that summarize clinical practice guidelines that direct people to different resources. Don't assume that your doctor knows all of this. It's impossible for busy physicians and other health professionals to keep up with all the evidence and knowledge. So that's why we at SCIP really try to translate all those journal articles, all those conference proceedings into like one pagers that you can just take in that will highlight some of the effective strategies. So don't be afraid to take things into your physician and share some of the learning and resources, because then it might not only benefit you, but it can also benefit other children and families.
Yeah, now another question comes into mind. So asking about what will you do about my children's pain creates an expectation that this should be managed. Would the same principle apply to when you communicate with your children when they're asking, oh, this is going to be painful, or I don't want to feel any pain, but then reassuring would actually have the reverse effect that we would think? Do we provide an expectation that yes, there will be pain, but it will be managed, or how do you go about that conversation?
Yeah, I mean, we're always honest with kids, like you are going to get a needle, but here are the things that we're going to do to manage your pain. And ideally, you're talking with your kid in advance about what their pain management strategy is. And again, I have 4 kids who I still take for vaccinations and needles. And when they were younger, I would talk to them about it. Now that they're older, I still do. Do you want a topical anesthetic cream on your arm or not? What should we bring with you to distract you during the procedure? What do you want to do after the needle? And also really making sure you're using child-friendly language to explain why. Because I think sometimes we don't take the time to explain to kids why they're having painful procedures. So this is a vaccine so that we can keep you healthy and so that you won't get serious diseases that could really be harmful to you or harmful to other people. Or we're going to the hospital. We need to test your blood. Your blood will tell us if there's something else going on with you. So we often assume that kids know what's going on or that they don't need to know what's going on. But when kids understand and have age appropriate explanations, it really makes a big difference.
Yeah, so I think that can be applied to not only procedures like needles, but also going to the physiotherapist. We're doing
Right.
some stretching, we're playing with toys, and this is why we're doing it, and not to say that it will be okay.
We have that in psychology all the time. And of course, in psychology, it can be very stigmatizing for kids to learn that they're going to see a psychologist. Does this mean the pain isn't all in my head, or do people think that I'm crazy? So, those simple explanations about how pain is really complicated. It's an interaction of how your body reacts and how your brain processes pain. And so, we're bringing in the whole team who are going to be working on pain from different perspectives. I think it's so important.
Now, we talked quite a bit about acute pain, particularly pertains to procedures. Now, let's talk about transitioning from acute pain to chronic pain. What does the research suggest about the relationship between a children's psychology and the risk of developing chronic pain after exposure to acute pain?
Interestingly, a lot of the research now looking, and this is a hot topic in the field, this transition from acute to chronic pain, even in the context of surgery, looking at people who've had surgery and then a certain portion of them will go on to experience chronic pain. And what we know, one of the most important predictors is how well managed the acute pain was. So we really emphasize the importance of having proper surgical pain management, postoperative pain management. And there are some people who really like to say, oh, I'm tough. I'm not going to worry about the pain after the surgery. And I explained to them, I was like, well, you don't understand. If you don't do a good job managing your pain through various strategies, you could be placing yourself at increased risk. But in the context of, I guess, children's pain and transition, we do know that there are certain psychological predictors. So, for example, having high degrees of anxiety, high degrees of depression, those sort of emotional variables can put you at increased risk for pain. But I really do try to get away from causal language when we're thinking about pain in that way, because it's really hard to disentangle that when you have pain, you feel anxious, you feel depressed. And so it becomes very difficult to sort out what is driving what. And there's also an evolving literature on sort of the impact of trauma and individuals' trauma reactions, and then how that puts them at risk for chronic pain. What we also know in the pediatric realm is that having a parent who has chronic pain, and we know lots of kids have parents with chronic pain because 1 in 5 individuals has chronic pain. So it's a very common experience, but that having a parent with chronic pain puts you at increased risk for having chronic pain yourself. And it's not really clear what drives that. It's probably a combination of biology and genetics, but also a combination of social learning and what you observe in your environment and what you learn about how to cope with pain. So there are various risk factors. It's very complicated. And I think it's part of raising awareness and having conversations about pain so that we can be well positioned to prevent pain.
I appreciate you saying that you want to prevent that causal language between how the children is feeling and whether that leads to pain. Now, in physiotherapy, we do talk a lot about managing yellow flags, which are anxieties, depression, other psychological and social factors. Would you say that even though we do want to be cautious, that we still want to help the children manage their anxiety and depression? And how do we best do that?
I think it's so important to talk about all aspects of pain. And I love that you do that as physiotherapists. I think that's so important because there are these linkages. Even though you and I are trained from different disciplines, we know that in the context of pain, but even outside of pain, that your mood and exercise, all of these things are related in very important ways. It's important that we discuss that, we honor it. I'm always very much like having pain causes depression and anxiety, but also when you're depressed and anxious, we just know from the gate control theory of pain, like how pain works, that when you have those mood states, it opens the gates. Like you're more likely to experience pain. And I think that's part of the education around pain. And they are very strong associates of pain. We know that they come together. And so it's really important to talk about them. And I like how you flag that as yellow flags, things to watch for, things that could negatively impact your pain. I think that's a really nice way to put it.
So apart from their mood, whether they have a parent with chronic pain and how well the acute pain is managed, we talked about these are the risk factors that increase the likelihood of developing chronic pain. What are some other ones that we tend to think less about, but as healthcare professionals that we can really do something to mitigate that risk factor?
I really think those are the most common ones that health professionals can look for and in our position to address. So those are typically the big ones that I would have on my list when I'm working with kids and families.
Now, if you are a parent with chronic pain, does the science suggest anything that you could do to reduce that being a risk factor for your children developing chronic pain?
Yeah, so there hasn't been as much prevention and intervention research with that population. And I think that's an area that does need a lot more focus. But a lot of the behavioral recommendations we use with children when they have pain, we would also recommend to parents. So things like making sure that you're not talking too much about your pain in front of your kid. And we're not saying you can't talk about it at all because it's a big part of your life, but making sure it's not becoming the only thing that you're talking about. And we do that with kids too. I mean, we often say, okay, you have a half hour today to touch base about your pain with your mom, but after that, you need to talk about other things. So we are trying to avoid pain being the primary focus. Same with how we model coping strategies. I had a back injury when my children were younger and I was icing it a lot. And I have a picture of one of my kids who I think was 2 at the time. And he pulled an ice pack out of the freezer and was rocking around with an ice pack on his back. I took a picture, I used it in talks just as an example of like, he learned that from me because I was in pain and he was seeing me in pain and he was emulating that. So I tell parents just to have that conversation. The fact that I have pain might be putting you at more risk for pain. What are we going to do about that? And how can we be supportive of each other? So it's tricky because adults with chronic pain already have the burden of their own pain. It's an added burden to worry about your own children. And I've often thought that it's a bit of a miss, like in adult self-management programs for pain, that they don't talk more about how your pain could be impacting your child. And again, I think this is an area that does need more research and more clinical attention as well.
Yeah, that's very interesting. And it seems like that a very important common thing we've talked about throughout is to have that conversation with your children. Like, don't think that they either know what's going on or they can't comprehend your explanation. To educate and have an honest conversation, that's really seemed to be very highly recommended in terms of managing children's pain and mitigating risk factors. We talked a little bit about chronic pain and interdisciplinary teams in chronic pain programs to help manage a children's chronic pain. I'm curious in that regard, are there any different considerations when a chronic pain team treats a children, like a pediatric client versus an adult client?
It's been a while since I've been in an adult pain clinic, but I think a lot of the fundamentals are the same. I think a lot of the concepts are very similar. And obviously, people who work with kids use different language and different approaches. I think the differences for me, and one of the things that I've always enjoyed about working in pediatrics is that when you're working with children, you're working with their families, you're working with their parents. And so you're bringing in support people just as part of their medical visits who are there to be able to help. It's a little harder with adults because they're not bringing their moms in with them or their dad. And so much of what we try to do often involves changing the environment and changing things that are going on around the child. So I've always appreciated the role of the family. And much of my research over the last 20 plus years is focused on families and what families do in the context of pain. I also think that it's different in pediatrics in that kids don't work. They're not managing jobs and a lot of the other issues around being disabled or trying to balance work. But, the work of childhood is going to school. And so that's another place where things look quite different is working with schools. We're always trying to keep kids in school, keeping kids in school, allowing them to function with their pain and be still present at school. When children with chronic pain have extended absences from school, it becomes quite problematic. So I think those are some of the differences in the context, but actually I think a lot of the treatment approaches, the fundamentals of treatment are very much the same.
So in terms of going back to the question of do's and don'ts, which is similar recommendations with what we would typically think about with managing chronic pain in adults.
I think it depends on the type of chronic pain and the medical advice, but going back to those 3 Ps again, what medications, what pharmacological interventions have been recommended, following those, what psychological interventions. I mean, typically what we do with children is a lot of like supporting coping skills, cognitive reframing, like I can manage this pain. I've dealt with this before, I can do it again. The psychology piece often involves working with the schools, helping develop graduated return to school plans if that's necessary, working with a therapist in a supportive way to identify any contributing factors, managing mood, anxiety, depression. And then I think the physical perspective as well. I mean, working with the physiotherapist on a prescribed treatment regimen that allows the child to keep moving and using physical strategies for intervention. So, yeah. We know, I mean, this is the hard part, that many children would benefit from that kind of interdisciplinary chronic pain treatment that aren't receiving it. And so that can be challenging. And there's all kinds of resources. There's a portal called the Power Over Pain portal that's available. So I think people are trying to make these fundamental components of treatment for chronic pain more accessible, recognizing that in the adult world and even in pediatrics, there can be very long waits to be seen by these interdisciplinary pain clinics, which is challenging.
Yeah, I appreciate you doing the best that you can to explain what can be done in managing pain with a little bit of physiotherapist mindset behind it. If listeners are interested in more from a physiotherapist perspective of managing children's complex pain and working with families, we do have an episode on it, episode number 12, with Amanda DeStresslin, who works at Alberta's Children's Hospital, and that is a very, very good episode to listen to. Moving onwards, looking into the future, continuing to make changes in how children's pain is managed. We talked a bit about the health standard. Can you briefly explain again this standard, like what is in there, why is it a standard, who should be reading this?
The standard it applies to hospital settings that provide inpatient, procedural, outpatient services, as well as community, regional, rehab hospitals. And the standard was really written for organizational leaders and health professionals who are providing care to infants all the way to adolescents. So it's really for 0 to 18 years of age and their families. And importantly, the standard really does recognize that children and families are equal members of the healthcare team. And at SCIP, we have taken a patients included perspective from the very beginning, in that we've had patients and families involved in all of our activities and our governance. Yes, so it's really taking an inclusive approach to the team. And the health standard is organized in 6 sections, and the health standard is available free of charge. You have to download it. So you have to put it in a cart and download it from the Health Standards Organization website. If you come to our SCIP website, there are easy links that you can click on to get to the health standard. But the main 6 sections include making pain manner, so having a pediatric pain management framework, making pain understood, which involves professional development to create a knowledgeable and confident workforce, making pain visible, so comprehensive pain assessment and reassessment, and making pain better. So there's a whole section on co-developing individualized care plans. There's a section again on multimodal pain management strategies as part of making pain better. And then finally, the last section is all about continuous quality improvement for pediatric pain management. So those are the 6 sections of the standard. And again, the standard was constructed so that anybody working in a healthcare setting with children can access it and reflect and implement components of the standard in their work.
The standard is a little bit of a big document. If any practitioners want to understand the document in a time-efficient manner, how would you advise them going about it? Or are there any resources that summarizes the content of the health standard?
On our SCIP website, we actually have an executive summary of the standard, so you can easily download and have that overview document. We also have linked on our website tools for health professionals that are a summary of the standard, as well as for parents and caregivers. So there's more accessible versions. And also what we've been starting to do, including as part of our Youth in Pain project, is create tools that are kind of aligned with the health standard and are, say, focused on implementing or bringing to life one component of this. So launching this health standard was a big goal of ours. It was part of our original application for SCIP when we were funded by the Networks of Centers of Excellence, and it was launched last year. We know from our colleagues at the Health Standards Organization, it's downloaded over 1,600 times. And I've lost count on the number of countries, but it's dozens and dozens of countries around the world. And our big focus at SCIP for the next 4 years is to ensure that the health standard is implemented. So health standards are only useful if they're adopted into the suite of standards that are required for accreditation by hospitals. And so that's really our focus. And so over the coming years, we're going to be targeting our efforts to improve access and implementation of the standard, and are very keen to work with people and always keen to engage with physical therapists. I have a physiotherapist that locally, Mike Sangster is his name, at the IWK Health Centre, who's been a great collaborator and a colleague over the years, but always happy to hear from people. This isn't just our work. It takes a village to be able to make a difference for children in pain. And we hope the standard is a bit of a roadmap for people. We're hoping that the standard can help get us all moving in the same direction, but we really do require interested individuals to come together to help make its implementation a reality.
Absolutely. The links to all of these resources will be linked in the show notes, and I highly encourage our audience to visit that and add to that download number.
Thank you.
So what are some things, apart from understanding this recently published standard, that our audience, either physiotherapists or researchers, can do for the cause of advocating for better pediatric pain management?
Talking about pain, using your voice to speak out when you think that pain could be managed better. Our health standard really frames poorly managed pain as like an adverse event. Like this is a patient safety issue. Managing pain isn't just a nice thing to do. It's part of quality care. And I think we are having to shift a lot from there's surveys that have shown that patients can rate really high satisfaction with their hospital stay despite having had a lot of pain. And to me, that signals that people expect to feel pain. They expect when they're in the hospital to feel a lot of pain. And we know that it doesn't have to be that way. I think recognizing that there are communities of individuals who are working on the problem of pain in children. We have a newsletter, we have social media people can follow and share. And I think that's really how we've seen change happen, is like one conversation, one person at a time. At our own health center, there are a group of what they call pain champions who've come together. I think there's like 70 people across the hospital who have taken pain as something that they're serious about, that they want to advocate for, and they've made amazing things happen. So yeah, like just talking about it, checking out our resources, looking for opportunities to be involved in different projects and initiatives, it all really helps. And I think that physiotherapists are such valuable members of the team and are often very much doing a lot of work at the front lines, but aren't always as connected into some of the projects and initiatives that are happening at a national level. So yeah, really inviting people in to reach out to us if they're interested.
That'll be awesome. If anyone is interested in participating in your effort, do they just go to the website and contact and want to be a part of it?
Yeah, reach out to us on our website. Again, we have a monthly newsletter where we advertise all the opportunities. Sometimes we have a working group we might be looking for people for. Don't be afraid. We have 6 hubs across the country in different environments, different cities. Reach out to one of our hubs or reach out to us centrally. And we try to stay active on social as well, sharing news and information so people can connect with us there as well.
On a higher level, what are some barriers or challenges with adopting the best practices of pain management in children?
Like anything in busy clinical settings, I think that it's easy to not be able to give pain the priority that it deserves. Sometimes people think that proper pain management takes time, even though we know that's not the case. Like we know that when pain is managed properly, procedures go more effectively and efficiently. So I think just those systemic barriers, attitudinal barriers, no one wants to see a kid in pain, but there's just often a lot of competing priorities. And so our job at SCIP has been to help make sure that pain stays front and center as a priority.
So, in the continuing work in SKIP of trying to make sure that the standards is implemented, apart from just having those conversations and helping hospital administrators understand that these are important, how would these barriers be addressed?
We're going to continue to follow our 4 key areas of focus. So, those include assessing readiness, collating evidence, and organizing resources. That's kind of one bucket. We're going to continue to produce tools and promote them. That's another area for us. We're going to continue to facilitate change because we realize that it's hard work to change. And we've had knowledge brokers across the country for the last 4 years who've really helped to make change possible. And we're going to continue to raise awareness and create a sense of urgency around children's pain. So, for us, those 4 areas that we describe on our website, and we have ongoing activities in all of those are really the places that we're going to put our energy because we believe that when you attack all of those, like you're providing a tool, you're also providing some support, you're creating public pressure by making sure that pain is something that's being talked about and covered in the media, and you're assessing people's readiness, like all of those things kind of work in coordination. And that's really how knowledge mobilization happens. And I think also one of the things that I've been really committed to is approaching this from a relationship perspective, like really helping create change through developing relationships and building relationships with patients, with healthcare providers, with researchers. It's an ecosystem that we live in that when we're all connected, we can make a difference.
That's very comprehensive. I see that on the Skip website or It Doesn't Have to Hurt website that there are also projects going on regarding juvenile arthritis pain and cancer pain in children. Can you explain a little bit more of those 2 topics and whether there are other topics coming up?
Yeah, so those are a couple of projects that are coming out of my research lab. And we have a student who has recently finished her PhD and is now at the University of Calgary, who has become a leading expert on pain and cancer survivors. Yvonne Brandelli is a PhD student of mine who's just graduated or just graduating, defended her thesis on the topic of arthritis and pain in children. And so those are examples of how, while Skip is busy mobilizing knowledge, we always need the new knowledge coming. So it's this incredible relationship between creating knowledge, mobilizing knowledge, and then when you're mobilizing knowledge, often gaps are identified. We were leading a large scale social media initiative called It Doesn't Have to Hurt about 10 years ago. We were providing all this evidence to parents, but then parents would say, well, what about teething pain? And we would be like, oh gosh, like we know so much about how to manage babies' pain from needles, but there's not a lot there. Growing pains, like that is a topic that we don't know a lot about. So it's great to be able to engage in knowledge production through my lab and then in working with others across the country on knowledge mobilization. So yeah, we've always got new questions coming up, new areas that we need to focus on. And we're really lucky in Canada to be one of the world's top producers of knowledge about pediatric pain. So we've been leading the world when it comes to publishing and creating new knowledge. And now I think we're really leading the world when it comes to mobilizing that knowledge through SKIP.
That's amazing. That's cool. Seems like a lot of things are going on and a lot of more exciting things are coming up. To draw this interview to a close, any concluding thoughts to our audience?
No, I think just thank you for being interested in children's pain. I think it's a topic that often gets ignored. Adult pain is such a huge issue and so important, but it's always great to create space to specifically focus on children and their pain. But Hope you'll follow along with us, and thank you for what you're doing, because this podcast is just a great example of another type of knowledge mobilization activity that helps to get the word out and helps to connect people. So I'm really grateful to you as well.
Absolutely. That's my pleasure. Love doing it, as you do too in your space. Thank you so much for your time, Christine.
Thank you.
Thank you for listening to this episode of Paincast on pediatric pain management. We hope this was informative and that you walk away with some practical tips. Paincast is a freely available resource to help you learn about pain and physiotherapy. We would really appreciate if you can support our podcast by subscribing and rating it on Spotify or Apple Podcasts, and share it with your network. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.